Hi everyone, I'm David Glazer, and I'm just here very quickly to do a couple of announcements and introduce Ann Smith, who's come in to do a presentation for us today on the practical import of ICD-10. So not many announcements, but first, next month's webinar, which will be on March 12th, is going to be frequently asked questions that we get. So Katie Ilton and I are going to go through as many questions as we can in an hour. It's going to be things like it's going to be for both clinics and hospitals. What time does time start for the 2 midnight rule? That one kind of applies to both. Do traditional Medicare rules apply to Medicare Advantage's services? Can you give discounts to non-Medicare patients? Just the kind of questions we get every day, and we'll try to pop through them, basically a minute a question. So if you want, send us questions. Please, if you can send it to Katie or me, probably better to Katie, and just put webinar question in your subject line, and we will be going through it's just straight questions and answers next month on March 12th. Second, if you want to ask a question today, if you see the mouse right here in the middle, go up right to the middle. A box should appear, and that will include a chat box. That's where you type your questions. And finally, don't forget, the internet sometimes goes haywire over the lunch hour. If sound gets intermittent, there's a dial-in number. Robert is typing that in the chat box, and you can see that. You can use that dial-in number if your sound goes kittywampus. So with those announcements complete, I'm going to turn this over to Ann. Ann has a lot of material today, so she may not have a lot of time to go through questions. Ann has been coding longer than I've been at this law firm, which is longer than I'd like to admit, but like over 20 years. So she's been doing this for a long time, and she's just going to talk about things you need to know about the changeover to ICD. So with that by way of background, Ann, take it away.
Thank you, David, and welcome everyone. The title of the presentation is Counting Down to ICD-10. I know that there are many of you on the line from places that have had a bad winter, but here in Minnesota, we always are counting down to spring. We just finished 43 days below freezing and 17 days below zero, and it's actually a kind of spring-like today, so that's a boost for everybody. Our agenda today is going to give some background on ICD-10-CM and a little bit on ICD-10-PCS, and we will talk about what those are. A lot of comparison on diagnosis codes in ICD-9 versus the new ICD-10. A fair amount on preparation and analysis, specifically training, the financial impact, and compliance concerns. We have geared the presentation, as the email invitation said, towards those who maybe have not done a lot of preparation yet. I suspect some of you have done most of the steps that we'll be talking about, but hopefully there will be some interesting information for you at any rate. We're also going to talk about some of the resources for ICD-10, which are numerous, and then, as David said, hopefully some time for questions. So the countdown is on. ICD-10 is ready for implementation October 1st of this year. If you're using a little countdown clock, we would put it at approximately 7 months, 1 week, 4 days, and 12 hours. The impact on healthcare organizations of all sizes will be huge. You probably have heard that. You may or may not be familiar with some of the reasons why. At this point, it truly does not appear that there will be any further delay. I have to be very honest and say I was somewhat surprised by the delay that was announced early in 2012. I know others were surprised. Many were hoping for a delay. I have heard some that were a little distressed by a delay because of all of the advanced work they had done. CMS has said that they are ready, and I am going to talk a little bit later about a timeline of some testing and so forth that CMS has recently updated. I actually got an email this morning regarding some of it. So nobody knows 100% for sure. A lot of physicians still, you hear murmurings that they're talking about delays, but at this point we don't think that's the case. Preparation is going to be the key to make a smooth transition, particularly with not very much time left. So let's get into some of the background for those that may not be real familiar with this transition. Right now, we have something called ICD-9. ICD stands for International Classification of Diseases. The 9th version is what is currently used, and it's used for diagnosis coding of both professional and facility claims. And then a portion of ICD-9 is also procedural coding for facilities. This will be replaced by ICD-10. ICD-9 has been around since 1977, so we're all very familiar with that. Both systems were developed by the World Health Organization, and the particular version for diagnosis coding is ICD-10-CM. The CM stands for Clinical Modification, and basically that's the United States version. The National Center for Healthcare Statistics is involved in development of the U.S. version. The other countries do have ICD-10, but typically then they would not be using the CM. They would have their own abbreviation added onto it. In addition to ICD-10-CM for diagnosis coding, there will be a version for facility procedures. The new name for that is ICD-10-PCS, standing for Procedure Classification System. If you're not aware, the CPT coding that we use for professional billing and outpatient services is not changing. CPT will remain the same as it always has. This is only the diagnosis coding on the professional side, or for everybody. In the facility side, it is only the procedures. The remainder of the industrial world has really been using ICD-10 since the 1980s, so a long time. Why do we need to change? There are a couple of intents that were stated for the change. One is for allowing better data collection overall, and because the rest of the world does use ICD-10, for better coordination of the international disease statistics worldwide. ICD-10 has been described as being much more consistent with current clinical practice. Certainly there have been plenty of updates to ICD-10 over the years, but a whole new system does, by its very nature, build in a lot of new practices and so forth. There's also the practical standpoint that an expanded code set was really needed. The current code format was literally running out of codes. There was nowhere to go to capture all of this additional information that was desired for statistical purposes. So that's another reason. Having more codes to choose from, which we will talk about, and much more specificity with ICD-10 is also in line with many of the quality initiatives. Those of you that work in physician practices are familiar with PQRS, the physician quality reporting. There are risk adjustment models and just numerous quality initiatives, either mandatory or sometimes even internal, that are done. And having a lot more specificity will really allow folks to get better reporting for that type of initiative. One stated advantage that we have seen for ICD-10 is enhanced automation of payments, with the idea being there will be more specificity, more detail, so less payer requests for additional documentation. That may not be the case on day one of ICD-10. It may or may not ever be the case, but it definitely is seen as a potential advantage of ICD-10. This type of major change does not come without some drawbacks or concerns. And in the case of ICD-10, there are some concerns both from revenue and compliance standpoints, and we will be going into those a little further as we get into the presentation here. So the implementation date, as I mentioned, is October 1st, 2014. ICD-10 is not something that we can choose to do as healthcare providers. It will be required. Those of you that are familiar with HIPAA know that HIPAA is not just privacy and security. HIPAA also has a portion called transaction code sets, which mandates the codes that need to be used for medical insurance claims. That includes your CPT codes, HCPCS codes, ICD-9 codes, and now it will include ICD-10. If you're interested in finding the precise references for those mandates, the original was in the Federal Register of January 16th, 2009. That was the point in time where ICD-10 was added. Back when they did it in 2009, they thought that the implementation date would be October 1st of 2013. So then when the Department of Health and Human Services announced the one-year postponement, which was announced April of 2012, then that September, on September 5th in the Federal Register, they did revise it to say that ICD-10 will be a required code set as of October 1st, 2014. So what are we doing right now with ICD-9? Those of you that are coders are well aware that it has been gradually being phased out. October 1st, 2011 was the last time that there were updates to both ICD-9 and to the draft version of ICD-10. We have had a draft version around since, I believe, approximately 2009 or so. Then October 1st, 2012, and this last October 1st, 2013, there were limited code updates to both systems, mainly just for new technologies and diseases, and also some error corrections, typos and things of that nature. And I have noticed, as I've been doing some training on ICD-10, that they have actually changed around a few of the codes and so forth. October 1st, 2014, then, there will still be only limited updates to ICD-10. That is when it will no longer be a draft, and it will be ready to go, and ICD-9 will not be in use for services after that date, for the most part, and we will talk about that a little further. And then October 1st, 2015 is announced as the time when regular updates to ICD-10 will begin. So how much more complex is ICD-10? Quite a bit, partly due to the sheer volume of codes. According to the Center for Disease Control, there are nearly 5 times as many ICD-10 diagnosis codes as there are in ICD-9, so we're up to about 70,000. But the ICD-10 PCS for the facility procedure codes, 19 times as many, so obviously a significant change. Some folks ask about a crosswalk. Can't we simply just crosswalk the codes? There are many versions of crosswalks available, some of them homegrown. One of them is a CMS product called GEMS, General Equivalency Mappings. It is meant more as a database so that all of these ICD-10 changes can be put into systems. Obviously, when you're going to 5 times as many codes or 19 times as many, there are going to be plenty of situations where a crosswalk is just not possible. And for the ICD-10 PCS, it really would not be possible anyway because of the nature of the new codes. There is a potential for having to use both ICD-9 and ICD-10, and obviously that will be a cumbersome situation and can cause concerns. Some examples of that would be date sensitivity. If we're looking at a physician's bill and the physician is going to charge for services rendered to an inpatient, the inpatient was admitted September 30th, 2014. stayed in the hospital until October 2nd, there is going to be the need for that physician services on September 30th to be reported with ICD-9 for the diagnosis reporting. And then for October 1st and 2nd, one would have to code under ICD-10. So that's one example. Another example would be non-covered entities under HIPAA. There are some situations where you're dealing with a non-covered entity. One example would be workers' comp. Those entities are not subject to HIPAA, and thus they are not required to transition to ICD-10. However, I think that there's a fair amount of thought out there that many of them will, simply because ICD-9 is not going to be supported any longer. It won't be updated, and there probably would be the point where those entities would want to transition to ICD-10 as well. But it is something to keep in mind. Specifically for the ICD-10-CM, which again are the diagnosis codes, how to look up the codes will be familiar to coders who have worked with ICD-9-CM. The manual looks a great deal like the ICD-9 manual, and they will be familiar with how to look up codes. The codes themselves certainly look different, and we will talk about that. There are some coding conventions and guidelines that will be different as well. As far as ICD-10 PCS, which are the procedure codes for inpatient reporting, the new system will bear little resemblance to the current one. The ICD-9 procedure codes were not very specific in most cases. ICD-10 PCS codes are extremely specific. They all require 7 characters. It's going to be starting with an alpha character and then have a mix of alpha or numeric. The letters I and O are not used to prevent confusion. The 7 characters represent various elements of the procedure, body systems, body parts, and so forth. There will be an index for ICD-10 PCS that will offer the first portion of the code, and then extremely detailed tables that will be used to find the remainder of the complete code. There are a lot of guidelines and instructions, but this is a huge change, and anatomy and physiology knowledge is really a must for coders working with ICD-10 PCS. It certainly is important for ICD-10-CM as well, but I think by its very nature, the PCS system is going to require that knowledge. There is a government training manual online, and it gives an example of surgery done on the common interosseous artery, and then sends the coder to the ulnar artery. Obviously, one would have to know that the interosseous artery would be coded as ulnar artery in order to code it. And then those 7 characters are going to include the section. In that case, it would be medical and surgical. The body system, which in this case would be upper artery. What they call the root operation. For that particular example, they used the phrase extirpation, which is not one that flows easily, but basically removing probably a foreign body or a clot. The body part, which is ulnar artery right. The approach, which is percutaneous. The device, which would be none in that particular example. And the qualifier, which is also none, but it could be something like diagnostic and so on. So very complex, much different, and a major, major change. Those of you out there with whom I've worked in the past know that I am not going to be any kind of ICD-10 PCS trainer because I work primarily on the physician professional side. So for our webinar today, we're going to show some specific examples from the diagnosis code set, which is ICD-10-CM. ICD-10-CM codes will all start with alpha characters. You may be familiar that under ICD-9, we only had a relatively small number of codes that were alpha, our V codes and E codes, and that was it. But now They're all going to start with an alpha character. Almost all of the letters of the alphabet are used, but not including I and O, which is very confusing because when you look at an I or an O at the beginning of a code, it's easily confused with a 1 or a 0, particularly because we were used to a lot of numeric diagnosis codes. The ICD-10-CM codes will be up to 7 possible characters, but they can have either 5, 6, or 7. You've maybe seen our example of a license plate before. We've used that on another webinar. One of the first things I thought of when I saw some of these long, drawn-out 7-digit codes was a license plate. And indeed, that is a real code. That particular one is a burn of the 3rd degree of multiple sites of the left shoulder and upper limb, except wrist and hand, initial encounter. So you can see how one code is capturing a lot of information and a great deal more specificity than we ever would have had under ICD-9. We know that it is a burn. We know how severe the burn is. We know it is more than one site. We know the specific sites and which side of the body they're on. And we know that this was the initial encounter. Much, much more information. So beyond the sheer numbers of codes and the changes in the look of the codes, one of the major features, good or bad, is the increase in specificity. There is going to be a lot of detail on the anatomic sites, severity of the condition, complications and manifestations of disease, and so forth, just to name a few. There are some concerns out there. Besides the fact that it's tougher to deal with so many codes, I have heard concerns about complications and providers saying, do we really want to report all of these complications and that kind of thing? So a lot of ramifications to be considered as we go forward. There are new coding concepts in ICD-10, new guidelines, some of the formats have changed and so on. Those will also need to be learned to ensure that your coding is complete and accurate and that the claims get paid. Some of the concepts are entirely new, and if a coder felt like, well, I can just pick up that ICD-10 manual because you look it up in the index and then you find it in the tabular list, and it's pretty much the same for the diagnosis codes, and then they would stumble along to one of the new concepts like the excludes 1 and excludes 2, it would be, it could potentially result in errors in the coding. So there is a lot of new stuff to learn, if you will. We'll look at a couple of comparisons here. Now, this first example is going to seem like, well, what is she talking about? This looks easy. ICD-9-CM, there were 3 codes for your basic essential hypertension. If I could see your faces, I would see some smiles because most of you are probably used to seeing the unspecified version, code 401.9. But in fact, there were 3 choices, malignant hypertension, benign hypertension, and the unspecified. In ICD-10, there is only 1 code for essential hypertension. They no longer differentiate between malignant and benign. As I said, all of these start with the letter of the alphabet, so it is I-10. Somebody with a sense of humor named it I-10 after ICD-10, I think. That example is the exception to the rule. We have tons more examples where ICD-10 has taken a diagnosis code from ICD-9 and drastically multiplied it. As you can see, we have acute serous otitis media, 1 code in ICD-9, 8 codes in ICD-10. So all of a sudden, we see the laterality. We have right ear, left ear, bilateral, or unspecified ear. And then also we have a choice for recurrent, again with right, left, bilateral, or unspecified. There are, in ICD-10, 67 different categories of codes related to the middle ear and the mastoid, 36 categories related to the external ear, 20 categories related to the inner ear, and roughly 40 related to other ear conditions such as hearing loss and so forth. So out of that, maybe 160 some codes, most of them, because we do have right and left ears, have choices for right, left, bilateral, and unspecified. So we're looking at probably 700 codes just related to ear conditions. That's nothing compared to when you get to some of the fractures. When I initially was going to be doing these slides, I thought it would be fun to show all of the forearm fractures, but I really had no idea just how many there were till I actually counted them. We had a fair number under ICD-9. There were 47 codes for forearm fractures. Obviously, that's because our forearm has two bones and there's all different types of fractures that can happen. But now under ICD-10, we have 186 codes just for a forearm fracture. Beyond those 186 code possibilities, it is also a requirement to complete those codes that one of an additional 16 choices will be put on the end of the code as a seventh character. None of those were requirements of ICD-9, so that is going to further expand that particular code category. I'll show you an example. Now again, we just need to adjust our slides here. There we go. Diagnosis code comparison. These are the 16 choices. And again, remember now, this is not for every fracture. Some fractures do not have this many additional characters to choose from. Some have quite a few. This is probably the forearm fracture, one of the categories with the most. But as you can see, that seventh character at the end of the code is going to indicate such things as initial encounter for a closed fracture or initial encounter for an open fracture of a specific type, subsequent encounter with routine healing, delayed healing, and so forth. So lots of choices to expand that code. And we're not done yet. After you've chosen one of the 186 new codes for your forearm fracture and have added one of the 16 characters, there are also additional codes to report what caused the fracture, where it happened, what the patient was doing at the time, and information specific to the patient's status at the time. It could look something like this. There we have a code for a displaced fracture of the right ulna. We have the external cause code, how it happened. We have what they call a place of occurrence code in ICD-10. Very specific. This example here is a garden or yard of a single-family private home. And believe me, there's lots of very specific choices. We have a code for the activity, what the person was doing at the time of the injury. And finally, what is being called a status code. In this particular example, it was civilian activity done for income or pay. Not all of these codes will always be needed for each encounter, nor do we know for sure how much detail payers are going to require. But technically, you do code all this for many of your injuries. Just as an aside, all of this falls under what was called the HIPAA Administrative Simplification Statute. I will not make any commentary on that. So the extensive code choices are not limited to injuries, even though we've had a lot of emphasis on that. There are several other categories that also have extremely specific codes or that may require 7 characters. So this is going to be a huge challenge, obviously, for coding and certainly for the good supporting documentation. Will we always need all this detail? Nobody knows for certain what payers are going to do. On the hospital side, most likely. On the physician side, I think certainly some of it will be needed under some circumstances and by some or all payers. A lot of that will remain to be seen. But certainly we want to try to beef up the documentation as best we can in anticipation of that. One of the myths that we've heard about ICD-10 is that there's no way to code unspecified. In the example I showed you for the otitis media, you can see that there are unspecified codes, and most categories of ICD-10 do have that as a choice. I think the big question there again is going to be, if you use an unspecified code, will that result in getting your claim paid, or will it result in a denial? Sometimes there simply is no other choice but unspecified because of the information available to the clinician at the time of the encounter. And we'll wait and see what happens with those denials. So let's move on to the preparation phase. As I mentioned earlier, many organizations have been planning and preparing probably since at least 2009, if not before. They've been establishing internal committees, maybe designating a lead person to coordinate their ICD-10 preparations, certainly getting the management aware of what's happening and getting them on board, communication with internal and external folks, internally particularly the medical staff, making sure they're aware of what's going on, working with vendors, payers, clearinghouses, other third-party billers, all of that's very important. For vendors, it isn't just the code sets, it's really all of the applications that use diagnosis codes, search engines, reporting capabilities, and so forth. One of the big things is testing. That's going to mean testing software for claims submissions, eligibility, quality reporting, really all of the systems that will interface with the ICD-10 codes. Storage capacity is a concern due to the number and the size of the codes. I mentioned earlier that CMS has said they are ready. As of October 1st, 2013, CMS said that all of their fee-for-service claims processing systems are ready for implementation. On October 1st, 2014, they continue to do some ongoing quarterly testing. They are developing plenty of tools. The CMS website is just a treasure trove of information about all of this. They have done some conversions on their NCDs, which are the national coverage determinations or policies. On the hospital side, DRG conversions, work on the outpatient claims editor, and so forth. So those tools can be found on the CMS website. I was reading today, as a result of an email I got, that CMS is setting up what they're calling acknowledgement testing the week of March 3rd through the 7th, 2014. And then depending upon how it goes, they said possibly later dates as well. That's going to be an opportunity to make sure that claims will be accepted. They're not going to be adjudicating claims, but the test facility will receive an acknowledgement as to how the testing is going. So that is definitely something you may wish to look into. CMS has also announced they will have the carriers publishing crosswalks to the LCDs or local carrier decisions as of April 2014. And then CMS plans this summer to do some actual adjudication of sample claims. My understanding right now is that that's only for selected provider groups, and I don't know what that selection process will be like or what it will consist of, but that will be something to watch for as well. One final note for those that may have a situation where systems just aren't ready at this point, and there's a concern that they may not be ready. CMS has also announced that their local carriers, or MACs, will have some free billing software that can be utilized. So all of those are things that you're going to want to check on a little further if you have a need in your organization for that. So what can be done in the 7.5 months that are left? Analysis is certainly important. analysis of how the ICD-9 codes are currently impacting your organization. Who uses the codes and in what manner? Obviously, coding and health information management, but it goes way beyond that, extending out to business office, providers, clinical staff, ancillary departments, finance, compliance, and so forth. Some will use the codes way more than others, but you do have to consider all of those potential uses for ICD-10. What resources and tools are you currently using? Looking at, obviously, electronic health records and billing systems, looking at any paper charge tickets or other billing documents you may have, policies, procedures, cheat sheets, patient information forms, history forms. Is there information you want to capture related to smoking and other tobacco use, height and weight, BMI, chronic conditions, all of those things? It's a good opportunity to kind of take stock of what forms are out there and how they may need to be adjusted or revised for ICD-10. What is your current workflow? What processes do you have in place right now? If the physicians or other providers are choosing the diagnosis codes themselves, is there coder review? If the coders are reviewing, to what extent? Is it 100% review or random or just certain codes? Certainly consideration should be given to how you can review during the transition time when there will definitely be some need for coder oversight. If the coders are currently assigning the diagnosis codes, provision should be made for the additional time that will be needed for that coding. What does your provider's current documentation look like? Does it support the use of a specific ICD-9 code right now, or is everything not otherwise specified? Are they including detail, such as right or left side? Obviously, that's going to be important, and I dare say required. Are they including acute or chronic, with or without complications, due to? Are they including that type of circumstance for the injury that would allow you to code how it happened and where it happened and so forth? Trimesters for pregnancy is going to be a requirement to complete many of the codes. So there's a lot of detail in the documentation that if it's not there now in ICD-9, it's doubtful that it will be in ICD-10 without some feedback to those providers and some work on that aspect. One way to go about that is to determine what codes you're using in highest volume. I know many of you out there have already done that. Depending upon the size of your organization or how many providers or how many specialties, you might be looking at the top 25 codes or the top 100 codes. Whatever you see in your reports seems to be a need. A report of all of the not otherwise specified codes that are currently used might also be useful. Then you can compare some samples of related documentation to what will be needed under ICD-10 to better support those particular disease conditions as far as the diagnosis code. Some coders are doing some dual coding as part of their training and for giving feedback where they're actually coding cases both with ICD-9 and ICD-10. Certainly not required right now and takes time, but can also be very useful. Once you know where you stand in terms of your current coding and documentation, that's going to be a big help in planning your strategy for the time that we have remaining. So let's talk about a little of that preparation. First of all, training. And then we'll talk about financial impact and some of the compliance concerns. Training is certainly key whenever we're faced with this type of change. Who needs to be trained? How much training do they need? Looking beyond the obvious, which are the coders and the providers, there is a need for training in at least most areas of the organization. Senior management is going to want to know about this, as is finance, regarding their reports and the financial impact, obviously. Department heads, clinical managers, nursing and other clinical staff, they're often involved in some of the coding choices. Business office, those that are working with denials and appeals, reception and front desk We can't skip them. Those folks are dealing with patients and sometimes with insurance companies as well. And then certainly the compliance and quality departments, both from a review and a reporting standpoint. So coder training. Obviously, coders are going to be your experts in ICD-10. If you have not thought about training, now is the time to get thinking about it and to be beginning that training. The amount of training, the format, the extent will vary a lot. Most of the industry estimates have talked about up to 16 hours for diagnosis coding and 40 or more hours for procedural coding. I will say for the diagnosis coding that for the formal training in a multi-specialty group, the 16 hours is probably about right. It might be somewhat less if specialty focused. However, as you could see, certain specialties are going to be hard hit by this, and there will be time needed to get to that expert level. But you do have to look beyond that formal training. 16 hours, 20 hours, whatever you do, of formal training is not going to be the end all and be all. A lot of organizations have chosen to develop a train the trainer or a super user type situation where either certain coders or their coding educators will be those internal experts, and then those individuals take the more formal training and then can go on to provide training to others within the organization. Regardless of the format, there should be an emphasis on instructional notes, other prompts found in ICD-10, and certainly the official coding guidelines that are part of ICD-10, just as they were with ICD-9. That is really the fundamental piece that is needed as a solid background so that the coder can more easily make the appropriate code choices. If the training is not including those things, in my opinion anyway, it would be less than effective. And it also would be doing a disservice for the coders, particularly those that have to take a proficiency exam, because they're going to need to know about those guidelines. In some of the training that we have done, we do see that the coders are generally comfortable with the setup of ICD-10-CM, how the manual works, as I said, how to find the codes. It is going to take some time to be familiar with some of the newer guidelines and so forth. But the main concerns expressed have really focused on the documentation that they're seeing, as well as some of the processes that can be put in place to capture information. For example, all of those codes that will require us to know whether it's the initial or the subsequent encounter. How are we going to know that? Beyond formal training, certainly it's good to encourage the coders to work with the new codes whenever possible so that they become more comfortable with them. There are plenty of resources out there. ICD-10 coding practice. There are webinars, there are journal articles, networking at local chapters of the coding professional organizations and so forth. All of those things will be very useful. When I took the trainer program, which was now a few years ago, that was actually only a day and a half. So obviously it was not the end all either. One really has to stick with it, follow up, do more reading. I think every time I look at the ICD-10 book, I learn more, and that will be the case as we go through this. Coders should be provided with appropriate resources and tools, obviously. The books can be helpful, even if they're not really coding with a book anymore. And then obviously, if you do have a system that's going to include drop-down boxes for choosing codes and so forth, they need to be familiar with what's in there. Physicians need training, other providers. Good documentation in equals good claims going out the door. So you do need to decide how it best will work for your organization. Many experts are saying at least 8 hours. I think in the real world, that's not always going to happen for physicians. But it is important to give them an understanding, get the word out, let them know the potential for denied claims, which will result in delays in payment and decreased RVUs and all of those important things, why it's necessary for them to beef up their documentation and be on track with ICD-10, offering smaller group or individual time and ongoing feedback is certainly important. And then keeping this in front of them between now and October of this year so that they're aware it is coming. If the providers at your organizations are the ones choosing the actual codes, do not wait until the clock ticks down. Start now. And in the initial days of actually using ICD-10, it's probably going to be important for them to have some prompts or other helps. Maybe it's even just a cheat sheet of their favorite diagnoses or whatever it might be. Training for others, business office staff, as we talked about, prior auth folks, quality review, the lab, radiology. That's just a few. They will need to know the basics. They will need to know how to find the codes that they deal with on a regular basis. But I think even more importantly, they need information on whom should they contact within the organization when they need help. One good news piece, if there's any nursing staff out there that are giving a lot of immunizations, I was a pediatric nurse and I know about giving a lot of immunizations. There are 30 codes right now in ICD-9 approximately for various types of immunizations. There's only one diagnosis code in ICD-10, Z23, which means we gave an immunization. It doesn't matter which one you gave. So one little piece of good news. And now you've memorized one code. Financial impact. Everybody's wondering about that. Experts have long warned about the impact. For example, claim denials. That's a big thing, obviously, or delays. Decreased coder productivity, coding errors, changes in reimbursement. Talking about claims denials, it's possible some payers may not be fully ready. I'm sure the big ones are, but some may not be. Increased scrutiny of claims is certainly going to happen with this big a change. There may be more requests for documentation from payers rather than less, at least initially. Maybe a slower appeals process. If the payers have built in some crosswalks into their reimbursement policies, there could be unintentional denials. Maybe duplicate claim submissions if claims are inadvertently sent in, coded both under ICD-9 and ICD-10. Decreased coder productivity, I'm sure you can say that with a high level of confidence. There's no doubt there will be some decrease in productivity going to such a complex and cumbersome new system. Perhaps due to some lack of training, besides the complexity, certainly there will be the need for checking with the physician or other provider on some of these issues. Based on the experience in other countries when they initially went to ICD-10, there are some estimates out there that it could take anywhere from 3 to 6 months for organizations to get back to their current productivity rates. And it wouldn't just be coding errors or omissions that could result in denials, but also then the potential for higher call volume and other functions. So employees that work with those functions are going to perhaps be busier as well. Changes in reimbursement, obviously for hospitals, shifts in DRGs. On the provider side, fee schedule changes due to updates in reimbursement policies. Eventually, there could be impact on some of the pay for performance and other accountable care activities. Since the codes haven't really been used yet, that issue is going to remain to be seen. So steps that can be taken now to help lessen the impact, certainly working with finance, with your accountants to evaluate the potential financial risk. CMS and other experts have recommended establishing a line of credit now in case that is needed once ICD-10 is implemented. Dealing with current backlog, if you already have 3 months of charges that haven't gone out the door, that's a problem, or will certainly be a problem when ICD-10 starts. Establishing some realistic goals for those days not billed would also be important. And then certainly when we get close to October 1st, get those ICD-9 claims out the door as best you can. Assessing current coding staffing levels, any scheduled absences during the transition, that will be important. Many organizations are planning for additional staff or some temporary staff. Some are looking into reassignment, not just for coding, but because of the higher anticipated call volumes, that kind of thing. If there is outsourcing done, you do want to make sure that the company that is doing that coding has coders with appropriate training and also do some monitoring of their work. Another key for planning is for follow-up after October 1st. It's not going to be October 2nd. Okay, that's good. We're done. That was a lot of work, but we're done. That's not going to happen. You are going to want to know if your coding process has slowed. How bad is it? Are we handling it okay? Do you need additional help? Are claims getting paid? Is the documentation adequately supporting the new codes? And we're going to briefly touch on compliance in that regard. You want to have a plan in place then to be looking at denials, assessing whether your financial goals are being met, giving some feedback to coders to help identify areas where they may need more training, additional training, more resources. They may have had their training so early they've forgotten it. It may not have been the right type. They may not have done anything with it for a long time. So there's a lot of considerations in that regard. Finally, compliance concerns. CMS actually has a statement on their website that says ICD-10 will allow for more precise methods of detecting fraud. If that doesn't put a chill up and down your spine, I don't know what will. So start now to plan for increased payer scrutiny, stepped up audit activity, emphasize the importance of good documentation, make sure physicians and providers are aware of this potential. I would say focus the attention on diagnosis, certainly, but if CMS steps up audit activity, it's not going to be probably limited to diagnosis. It can naturally lead to more, such as E&M coding and so on. So you do want to maintain a robust internal coding and documentation review process. Regular external reviews, they should be part of your compliance plan now, and you don't want to stop that or put it off. It's going to be more important than ever. Prioritize those areas that may need the most attention by coders and coding educators. Maybe you have some providers that just need a little more scrutiny and others that do not. Don't forget to give feedback. Providers can learn this if they're given the appropriate feedback. And if you don't already have a relationship with a team of health law attorneys, this would be a good time to establish that. I just happen to know a bunch of really good ones in case you're interested. So ready or not, ICD-10 is coming. It will be here before we know it. If you have not done much yet, it is definitely time to get that plan going, get your key players trained, and ready yourself for this major change. There are numerous resources available. Our firm, which is called Frederickson Healthcare Consulting, does do ICD-10 CM training. We also have partnered with Clifton Larson Allen when there's a need for more than one trainer, and also they do have the capability of ICD-10 PCS training. Some other resources that CMS has recommended. The first one there is the Healthcare Information and Management Systems Organization. They do have some cost productivity modeling tools. I think they may be geared primarily towards hospital, but certainly some good information. The American Medical Association, the Center for Disease Control. WEDI is the work group for electronic data interchange. It's kind of an IT advisor, if you will. A lot of information on that website. And then the Health Information Management and Coding Specialty Organizations, such as AHIMA, which is AHIMA.org. That's the American Health Information Management Association. And the AAPC.com, which is American Academy of Professional Coders. They have a lot of information on trends and topics, tools, assessments, training, and so on. And do not forget, as I said, cms.gov/ICD-10. Both CMS and your local carrier website are going to be great resources for you. And by the way, we now have 7 months, 1 week, 4 days, and just a little over 11 hours left. So the countdown is definitely on. And we have just a few minutes for questions, so we will try to take a few of those. This first one, do we really believe that ICD-10 coding will improve research opportunities? I am highly skeptical. Knowing whether it is the right E or left knee is not important in research. Give me an example of a real ICD-10 code that is better than a single or even multiple ICD-9 codes in an important clinical situation. Well, I would have to say I did not develop ICD-10, and I certainly have some skepticism as well. Obviously, there's going to be a lot more data collected, whether it's used appropriately or is useful in some situations probably remains to be seen. If the EHR software helps the provider select an ICD-10 code, is that sufficient documentation, or do the various components of the ICD-10 code, laterality, location, initial visit, need to be in the provider's actual clinical note? I think it's going to vary a little bit based on the type of system that you have. We probably would not want to see an entire encounter note without any detail and then a very detailed code chosen. I think that's sort of counterintuitive. And then, again, depending upon your system, will the codes that are chosen reflect information that is going to be payable or not? So I think we have a lot of answers that remain to be seen, and this next question definitely lends itself to that. This person asked, or it says, we get paid for unspecified codes in ICD-9. Why are we so worried that we will suddenly not get paid for the unspecified codes? I think it's not maybe so much a worry, at least on my part. There's certainly a lot of worry out there. I think it's more of a anticipation. What will this mean as far as the payers? We may be able to tell a little more from CMS once they do publish that information. I believe it was April. They're talking about their national coverage determinations being available with some ICD-10 crosswalk information. That may be very telling. I think there's a lot of things where you either won't know a specific code during that encounter with the patient, or obviously where the provider will not have documented it, and it's going to remain to be seen. I would guess the payers potentially could look at this as an opportunity to require more specificity. I'm sure CMS probably does, or they wouldn't have gone into ICD-10. But do I think every unspecified code used is going to be denied? Not at all. I don't think that's the case. But we are speculating here. We're all going to know a lot more about this come about November or so, when we've had some claims going in. A small outpatient clinic, do we still need to know and use ICD-10 PCS? Not as far as I'm aware. The ICD-10 PCS is going to be procedural coding only for inpatient facility coding. So it would not be done for outpatient things. For providers that use note templates, such as smart phrases, how do you recommend they update those templates to comply with ICD-10 standards? I think a big piece of that is going to be looking at those frequently used codes. What codes are you dealing with in the most volume? What are your templates and smart phrases there? If it's a condition that traditionally we didn't have to know if it was mild or moderate or severe, or if it was recurrent, or if it was chronic or acute, that kind of thing. Some of these extra adjectives and definitions that have been put on codes. I think if you compare what you've got for those smart phrases with what those same diagnosis codes look like in ICD-10, that will be a big step in knowing exactly what you should build into those phrases. And I think we have maybe 1 minute left, so we'll look at another question here. My understanding is that the causation codes, fall in, bathtub, and private home, were not required. Is that not true? Will the vast number of causation codes, with the vast number, how does the provider know what to document? Again, I think it's going to remain to be seen. The initial encounter, if one is doing complete coding for most injuries, the guidelines will tell you to add all of those external cause codes, which includes the place of occurrence and the activity and so forth. Subsequent encounters, you do not need all of those extra codes. Now, again, that's pure coding. That's what the coders are definitely going to want to do for their, if they're taking a proficiency exam. I think we'll just have to wait and see what the payers do with that. I think we are out of time here. I'm sorry that we don't have time for more questions. We did get a fair number of them. Thank you very much for your attention, and good luck with ICD-10.